I mentioned this, they have a very circular, deep, punchy appearance, and again, shiny leg, no hair. No hair across those toes, and you see how it's got a deeper, punchy appearance. Again, there's the gangrenous. And there's the toes. So I mentioned this before, just so y'all are aware of this, because this does happen. You know, if you're taking care of this patient and they're in a nursing home patient, the physician will allow this to auto-amputate, which means it will fall off on its own. So you should be aware of that, if that's what's happening, and you know, if it falls off in your glove kind of thing, be prepared for that. Or while they're walking or moving them, I mean, we do have patients that do that, and so we just, you know, dispose of the biohazard and move on.
That was my question, what do you do?
Yeah, you just dispose of it in the biohazard. I mean, it's not like it's gonna be a secret that this is happening. Okay, so you're gonna know that that's what's happening. But if you go into, and you might ask yourself, okay, well, why don't they just go in and surgically take those off? Because if I go in surgery, that's gonna create another trauma. And it's gonna create inflammation and all that stuff that's happening there. And I don't wanna do that. So I've restored flow, or they've got flow to that point, and they're just, you know, the tissue will actually separate. It will fall off and it will heal around. I mean, it does auto-amputate. You will also see this phenomenon occur in where you have ischemic events that happen in the tiny capillaries, like from Coumadin reactions and things like that, where they will throw tiny clots to like a toe, and that toe will turn black and fall off. And it's only that toe. The rest of them have adequate circulation. They just had an ischemic event in toes or tips. So just so y'all are aware of that. So here's more toes. Okay. So, this is again an arterial ulcer, and I'll show you this because when we treat these patients, you do not want to let it get to this. Because can y'all see that those tendons are just totally dried out? Well, when you dry your tendon out, it loses function. So when you have a patient with exposed tendon, the most critical thing is that you keep that tendon moist. Whatever you have to put on, gels, whatever, you know, we do Vaseline gauzes, Adaptix, things like that. We do whatever we can to keep that tendon moist. Because when you dry it out, it's gone. It will die and desiccate. So just keep that in mind. Okay, so here's an amputation that happened. And I wanted to point out to you guys, you see the bone sticking out of it up there? That's a problem when this happens, you know, because you have to accommodate for a flap coming up over the bone. And that's really important when y'all are dealing with stumps, like leg stumps, that they have adequate padding on the bone that they have amputated. So, just as an FYI, but this is what it looked like before, and this is how much they decided to take off. Okay, and so the violet stuff that you all see on there, that is gentilia violet, which is used to dry things out. And this occurred because the guy decided to use a blow dryer on his toe.
What was he doing? Trying to dry his feet?
Well, he was trying to get them warm because they're cold as ice because they have no flow to them. And the blow dryer got too hot and it burned and created even more. So again, I mean, you have to teach them, protect your feet. Put your hand in the water and make sure the water is not too hot before you stick your feet in the water, always. Especially if they can't feel it. You have to make sure that they know. One thing I did want to mention with arterial wounds is, you know, I told you mostly on the toe tips, but they occur anywhere, again, we'll reiterate this, at the level of ischemia. So, you can have patients who have lost both legs and suddenly their fingers start turning black because they have poor flow to the fingers. So, and I'll show you some more pictures in just a second. I think I have. You can have ischemia to just one leg. You see this foot. And again, this is a dry gangrene. You see it's not draining. We leave it alone. We don't even attempt to. We just pain with Betadine and leave it alone. Because they're not going to have an amputation. This patient chose hospice, and so we just maintain it. Okay, So I wanted to show you guys this. So when these patients, because they have such poor perfusion, when they get subtle signs and symptoms of infection, that means they have a major full-blown infection and it's a problem. It's a limb-threatening problem. So I want you all to see, do y'all notice the redness that's right here? Even though that looks like, oh, it might not be nothing, that's something big. That actually cost this patient his foot because it was infected. They don't have perfusion going, so there's nothing there to help them fight this infection. There's nothing there to create inflammation. So they really have a huge problem with fighting infection off. And then when you try to treat them with an antibiotic, I can't get the antibiotic there because I can't get blood flow there, right? So any infection is problematic. That's why these patients are often, these wounds are often treated with antimicrobials to try to prevent that and head that off. Again, you see the toes are all dying. So these are amputations, y'all can see some of these. Anywhere you have a level of perfusion, so I'll go back and show you guys this. You think this is awful, this person no longer has a penis. Guess what? If you don't have blood flow to your penis, it doesn't stay there. If you don't have blood flow to your nipples, it doesn't stay there. And when patients have advanced Raynaud's, Berger's disease, it will get that bad. And so I have this example of this little lady. I think I have a picture here. Maybe one of these later ones. She smokes. She's a smoker, had Raynaud's, Berger's disease, very advanced disease. No legs, one arm gone, and they had to take off her breast because it was ischemic. But she had 2 fingers left. So she calls to complain. She calls to complain because the nurse is on her about quitting smoking. Okay. The horse, the cows, the sheep, the ducks, they're all going out of the barn at that point. This is a waste of time for you to sit there and gripe at somebody about smoking when they have 2 fingers left to hold a cigarette. I mean, you know what I'm saying? So you just pick and choose your battles in that case. I mean, if we were going to stop smoking, that should have been 20 years ago. So I just want y'all to know that you have patients, they're going to tell you, I'm not going to quit, and you just got to live with it. Okay, so we do ABIs, and I explained to y'all what that was. There's also, with ABIs, you can get false positives because you can get calcification of the arteries in your diabetic patients. So we also do toe pressures, Doppler studies, and then they do arteriograms that usually piggyback onto an arterial a procedure of some sort, like a bypass or a arthrectomy, something like that. Okay. So I included this for your reference about the ABIs. Anything below 0.5 is severe ischemia, which I mentioned that before. And here's the segmental Doppler study. So I wanted to show you guys. So what they do is they actually check it in segments. And by doing this, they can find out where the blockage actually is, in what segment of the leg, and how bad it is. So it'll tell you where that is. So in some patients, they can actually open up flow. They can do, just like they do an angioplasty in the arteries of your heart, they do them in your legs as well and open that up. They can also bypass with an artery, or they can actually go in and actually cut that out, the plaque out, to open that flow back up. So we can make a big change. And I have some pictures here in just a second, I think, to show you guys. Yes. Can you guys see how this doesn't have anything flowing in these legs? Right? Now look. See, if you open the level of ischemia where they identify them, it will open up the arteries. And it's the difference in a patient healing or not healing. Right?
Amputation and not amputation.
Yes.
How soon do you have to catch it to be able to save the lower extremities?
Actually, so, I showed you some pictures of like toes that were black. When that toe is black and it's gone to that point, it's gone, okay? But if I can actually go in and check their arteries, do a procedure, and open up flow, it might be just that toe as opposed to that whole leg, okay? But if I can check it before you have any wounds, because you have intermittent claudication, and I can identify that and treat you with meds and a procedure, then I can stop that before you develop any wounds. Does that make sense? So, and it really depends on how bad it is. Now, having said that, remember the chickens and the ducks all gone out of the barn? When you have diabetes and you have no eyesight and no kidneys because you have lost such flow in your tiny vessels, I'm not gonna be able to fix your feet. Do you know what I'm saying? That's why a lot of people that are on dialysis have limbs that are gone, because it has progressed to the point that, you know, you can't go back and fix those tiny arteries. So we're talking about bigger arteries that we can actually open up flow and catch much sooner. Does that make sense? So I guess what I'm saying is you can't fix everybody, but you do try. Okay, so again, pretty classic arterial foot. And the leg, you all notice that leg is very shiny, no hair growing on it, very taut, right? Pretty classic for arterial. Okay, so any questions about arterial wounds? You guys know what the signs of those are, what you're looking for. Okay, so now we're gonna talk about venous wounds. And remember I told you this is the flow back up to the heart. So the way the venous system works, does anybody know how your veins work?
Every time you contract the muscle, it pushes it back up.
Pushes it back up. Now what is in your veins that keep that from going back down?
Valves.
Valves. Very good. So when those valves no longer work and you get a backflow of blood is when you have a problem, and that's the venous insufficiency and we develop ulceration. So that's what's happening there, is your valves are no longer working appropriately. That can be caused by a variety of things, or a combination of things. It can be caused by the fact that you're not active anymore and you're sitting all the time, and so you're not getting pumping, and so therefore you get congestion and it's stretching. Or it can be because you're standing and you're not getting contraction. And it can also be because you had an injury to those valves, like a blood clot or some kind of thrombosis to those valves that make them not work. Any of those things can be the result of that. It's very common, and it accounts for, like, of the 3 types of leg ulcers we're talking about, it accounts for 80%. And I will tell you, I see an enormous amount of venous insufficiency. It's probably the most common type of thing that we treat. So they're located on what's called the gaiter area, or the medial malleolus. So think about the base of your calf to the top of your ankle, the area right there. Like if someone come up, and that's where you're gonna see the most. Now, when they get progressive, they can go all the way up to your knee and kind of down onto your foot, but they're gonna start generally in that area. You will have nice normal pedal pulses. You'll have good granulation. Usually there's not a lot of necrotic tissue. I have never in my entire career ever seen eschar on a venous ulcer. It just doesn't happen because they have, they're nice and moist, and you just don't develop that dry eschar. So you're not gonna see that type of thing on these. Even though they look really bad, they're infinitely treatable if you do compression. So you'll get normal capillary refill. Usually they have edema, that's the biggest thing. And I'll just tell you guys, they're ugly. They're just very ugly when you're looking at them. See this typical venous ulcer, they're just very, they cover the entire skin. They have very irregular edges. You can see this one, you know, this white that you're seeing here, this that looks white, this is skin. So it skips and starts all in their skin, if you will. But it's hard to dress that and protect that skin from drainage because it's all intermixed within the ulcer itself. They often will have dermatitis that goes along with it, where it's scaly and itchy, and they want to scratch all the time, and their legs are just scales, you know, just falling off scaly skin. Here's another example. You see it's got the irregular edges, and you'll notice the brown staining, and also notice, can you all see the hair growing on this person's leg? They will still have those structures like hair growth, warm feet, all of those things, even though they have an ulcer. And here's another one, and again, you'll see the hair growing on his legs. See that? And then the brown staining there. Very irregular shapes. So I'm gonna skip through some of these so you guys can kind of see. And you notice the common thing, where are they all located in that area of the leg I told you? Right? On blood. Okay. Skip through here so y'all can get to the train. Okay. So how do you improve these is you have to manage your venous return, which you can elevate your legs, and that involves it elevating higher than the level of the heart. But you also do compression. That's the standard of care, is we actually wrap the legs and do compression on them. If they can tolerate it, at 30 millimeters or mercury compression at the ankle. So you begin with compression wraps to reduce the edema. Once the edema is down, then they go into a compression stocking. That stocking maintains them, okay? So wraps are short term, stockings are the long term. So you want to try to avoid irritants to their legs, anything with perfumes, dyes, anything like that. We use emollients on the peri-wound skin. We use corticosteroids for the dermatitis that's itching, moist wound healing, and we try to, again, do compression and manage the edema. You see this part where it says don't assume diuretics are needed? So that is a common mistake that people make, is thinking, okay, well, they need a diuretic to get rid of this fluid. The fluid is actually in the interstitial spaces, okay? It's not in the circulating volume. So until you move the fluid back into the circulating volume, you are not going to get rid of it that way. So you're going to be killing somebody's kidneys with all this diuretic, and they're going to be dry and dehydrated, and their legs are still going to be hugely swollen. You can't just assume that you're going to put them on a diuretic and get rid of this. Does that make sense? Now, if they're on a diuretic, they should definitely be taking that for whatever they're on it for, CHF or whatever. But we don't prescribe diuretics. Diuretics is not an appropriate treatment for venous insufficiency. It's not going to fix the problem, okay? So just wanted to bring that up in case y'all have questions about that. So we have compression, and we have what's called inelastic and elastic compression. So the inelastic, which you'll see used a lot, is like an Una boot, which it doesn't stretch, it's a short stretch. So has anybody ever put on an Una boot? Seen an Una boot? So it's a zinc-based wrap, gauze wrap, basically, and it's wrapped from your toes to the base of your knee. And you'll always go in that direction anytime you apply bandage. Doesn't matter what the bandage is. We always go back toward the heart, right? When y'all are wrapping, y'all don't start at the elbow and wrap to the wrist. You start at the wrist and wrap to the elbow, right? Because you go with the flow of the veins for the heart, so you don't damage those valves. Same thing with your legs. You don't go back down, you start at the base of the toes, you come to the base of the knee. Then we put behind that Una boot, that zinc wrap, we put a Coban layer. And then when they walk, because it's inelastic and the muscle contracts out, right, it meets that resistance, and that will cause the veins to collapse and propel the blood. Does that make sense? Y'all with me on that? Now, the problem is if you're really swollen and you have an inelastic bandage on there and your swelling goes down, that inelastic bandage don't come with you, right? So it's still big around. And so what happens is it'll fall down, and then you'll swell above it, and it'll constrict. So you have to make sure that you change that to start with at very frequent intervals, and that you watch it closely, because it will change and you'll end up with a mess if you're not careful. So we like to use elastic bandages when we can, because it recovers better. So here's what it looks like totally on. And this is somebody that decided to apply it in the middle of the leg, just wrap over the ulcer. You can't do that. Remember, always when you're compressing, toes to knee. Okay, and so here's another one of inappropriately applied bandage. This is where somebody started at the ankle. See what that did to the foot? Big swollen foot, and then you have these big bulges. So if you're wrapping right, you dorsiflex the foot, and you should have a 50% overlap, and you should not have, when you put this on, you shouldn't have striations in color with that Coban. You know what I'm saying? You'll be able to see. It should be exact overlap. And what the idea is you're getting uniform compression from the toes to the knee. If you don't have it uniform, it will swell in and about the gaps. Does that make sense to you all? Can you visualize what I'm saying? Which is what happened here. See, it's not uniform and you have big gaps. You can also create pressure ulcers from this if you don't pad the wrapping. So there's a cast padding that comes with lots of wrapping, so that we make sure that we don't cut into the foot. And then by dorsiflexing the foot, you can also make sure you don't get a cut in to the top of the foot. So while these patients have good flow, if you don't put on compression right, you can actually hurt somebody and cause problems. So it's very important that you be sure that you're comfortable with it and know if you ever have to wrap somebody. The long-term management, we move them to stockings. And again, I have examples of stockings, but I didn't bring them because of COVID. But if you're interested, all of those websites are there for you to look at. We like to use where I work, is a Velcro stocking, because a lot of patients can't reach and pull up. We do have some with stocking daughters that can do that, but the Velcro one actually goes and they just go across like this. And then it has a little guide that lets them measure to make sure the compression level is right. So they can manage it better than something tight that's pulled up, because they can adjust this. So, I will tell you that most of my patients go somewhere between 20 to 30 millimeters of mercury. An Una boot is somewhere between 16 and 18, if you're wondering about that. So it's a little more with the stockings. That's another thing about the Velcro, is I can let them loosen that up a little bit. Because a lot of my patients have what's called a mixed disease, which means they have a mild arterial component to go along with their venous insufficiency. So I have to be cognizant of that and not get too much pressure on them. Okay, so here's a stocking donor. TED hose, they are not appropriate compression. They're anti-embolism stockings. And just to give you not to get into too much of the science about it, they don't compress where they're supposed to for a venous insufficiency patient, so they don't work well. And patients hate getting them on and off, and it's a mess, and it shouldn't be that way. So if you happen to be requesting compression stockings or talking about that, TED hose are not appropriate. Neither are ACE wraps. They don't provide therapeutic compression. However, I will tell you that we do use ACE on patients who literally can't tolerate anything else as a last resort. But that's not the most therapeutic compression that you're gonna have. Okay, then we get into compression pumps. If they fail at that, we have a lot of patients that use these, and I really like them, because it's a cyclic compression, and it doesn't, even if your patient has an arterial problem, it's not a sustained squeezing, it's a pumping action that happens, so they can tolerate that. We also use these for our lymphedema patient. And not just the pneumatic pumps, but any compression is contraindicated for somebody who has an active DVT. I'm sure y'all can understand why. We don't wanna send any clots moving.
Do you see a Medicare pay for those in the home?
Mhm.
Good,
They will. You have to fail at compression
okay.
stockings. And then they will cover them. Also, if you have a diagnosis of lymphedema, they will cover them. And we see a lot of good many patients that don't have primary lymphedema, that have lymphedema as a result of their long-term venous insufficiency. And so they have mixed venous and lymphedema, and we can get them covered that way as well. Okay, so contraindications to compression, why we wouldn't compress somebody, as I said, active DVTs. You also don't compress patients if they have CHF that's uncompensated, or what we call uncompensated CHF, meaning if I have ascites, I have poor lung sounds, which I realize you guys will not be doing that. Everybody know what ascites is, fluid on their abdomen. If they're already in fluid overload, where they have clinical manifestations of CHF, shortness of breath, all of that, we don't move more fluid for them to drown in, so to speak, if that makes sense. So we wait till that CHF is under control. And you may have patients that are in what we call end-stage CHF, which really, they may be transitioning to hospice, or, you know, they're at the last stages of CHF. We don't compress those patients, even though their legs might be weeping, you know, because you're gonna make them really uncomfortable, and it's gonna create problems. So, you know, you just have to know those patients are not appropriate. And then we don't compress patients with arterial disease that is significant, because we can shut down blood flow. So the arterial disease takes preference for us managing those patients. Any questions about that? Okay, lymphedema. You can have chronic lymphedema, or what we think of as primary lymphedema. There is no cure for that. It can develop in one part of the limb or both parts of the limb. So for us, we have lymphedema, that's secondary lymphedema, that's usually in both limbs as a result of their chronic venous insufficiency. But I just want to show you guys the difference in that, so that you guys have an idea. These are lymphedema patients. So, I showed you the chronic venous patients. You can see that the skin changes that occur here are significantly different than the skin changes for those patients. This is also very hard. When you feel it, it's almost like an elephant, what you imagine an elephant skin is like. So you can't compress this when it's progressed to this point. It can also be really soft, like this lady. And you see how the changes really haven't happened in her skin yet, but you see that you can't see her toes for the lymphedema. So you can't just wrap this. It's not as simple as all that. So what happens here in these patients is they need to see a specialist, a lymphedema specialist. They will do manual lymph massage and start to massage this and open up those lymph channels, especially if their skin is still soft like this and the tissues are supple. They can actually do massage and open that up, start moving the fluid that way. And then when we do compress, what we have to do is use padding. And you will actually have to pad in and around these folds. You'll build those out with padding so that when you put compression on, you're compressing the whole limb instead of squishing down the tissues. Does that make sense? So if you have deficits, you want to think about any kind of compression as a cylinder going up with consistent compression from top to bottom, right? So in order to do that, to make the compression even as you go up, you have to fill in, and there's padding made for that actually lets you fill in any deficits in that leg. So if you ever take care of a patient, and I don't think I have a picture of it, but have what we call bottle legs. So they'll have these really skinny ankles, and it will almost form like a pop bottle or a jug, and it'll go up, and then it'll kind of level out and go like this, okay? And so you end up with a gap, and when you try to wrap, you can have like a 2 to 4 inch gap. I've seen it that big. When you're wrapping and you end up with this gap there, you can't have that. That won't work, for doing compression. So what you have to do is you have to take padding and you have to build their ankle all the way out till you get even with where the bottle goes up. And then when you wrap, you'll get a nice cylinder to move up. Does that make sense? And that's with your venous or lymphedema patients. Anybody you're wrapping, you have to create that nice cylinder with padding. So again, if you guys can see, this lady has little tiny thighs up there if you see them, and this is her lymphedema legs, and they're still soft, so you can actually start to compress those, do manual lymph massage and move them. And it's a bilateral lymphedema. Sometimes you'll get unilateral lymphedema, especially in primary lymphedema, but often in our patients they're bilateral. Also, one thing to mention, you all see how her feet look and those flat, the feet before. With a venous patient, typically the edema is more in the leg and the feet are not so involved. Okay, with just venous insufficiency. So here's another patient. Now see, this has already become hardened and calcified, and so it's very difficult then for you to do compression or to change that tissue. Okay. And this is a patient, when you have patients that are morbidly obese, you will see this very often when you're taking care of those, and so I want to mention that to you guys because as therapists you may see a lot of these patients. Lymphedema is one of the consequences of that because they don't move as much, and so you'll see a lot of lymphedema with them. So not only is the limb big, they got lymphedema on top of that. Yeah?
How do you differentiate between lipedema and lymphedema in this case here?
Okay, that's gonna be a big question, because that, the lymphedema is the lymph passages. The lipodema, if you think about it, has to do with the fat. And it may not even appear as swelling when you do that. It's got a whole different presentation. So, but that can occur in patients that are morbidly obese too. But these patients typically are, what I'm thinking about is patients who have hangover and wherever you, like, very commonly. Y'all see those patients that sit with a big pannus and they spread their legs and then the pannus hangs down? What you don't realize is that's not all fat. A lot of that is fluid because it's in a dependent position all the time. And there's nothing to make it go back into their body, right? Because it's always hanging down. So that's what you have, is they're always hanging in a place that they shouldn't be, and you're gonna end up with a lot of fluid catching.
How long does it take to get to this point?
To this point, usually with lymphedema it's years. And I'm gonna tell you something, y'all are gonna go in Walmart, I promise you. You'll go to Walmart in a few days and you'll be like, that patient has lymphedema, I know that. Cause you identify it now. How many people do y'all go diagnose at Walmart? Come on, when they're walking, you find all the PT things and you think, yeah. So you'll see that. They're not compliant, cause it's a pain in the butt to wrap your leg every day and wear your stockings. When it's 100 degrees and they're hot, people don't wanna do them. So when you have your slip up and you say, I'm not wearing that stocking today, it's too hot, I'm not doing it. Tomorrow, when you go put that stocking on, you still have the swelling and residual from the day before where you didn't put that on, and you're not able to get it on. And then it goes, and it goes, and it goes, and then you can't get it on, and somebody has to start over with your treatment. And so they've been at this for years. So it's not just an overnight thing, and they're not compliant. Just like, you guys, I'm sure every one of us has something we're not compliant with. These are the same kind of patients that they don't like to do. What'd you say? Okay, guys, we are all done for today. Anybody have any questions about anything we talked about? Did y'all learn something new today?